Welcome to our webinar titled Cytopenia Management in Low Risk MDS. Thank you so much for joining us today. My name is Lee Clark, I'm the Director of Patient Programs, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors, Amogen, Apellis, Tahoe Oncology, Alexion, and Merck, and the generous support of our patients, families, and caregivers for supporting the webinar today. Before we get started with the webinar, I'd like to let you know about an opportunity at the Foundation, which is to join one of our support groups. Our support groups are all virtual, and the groups are led by patients and caregivers just like you, who host meetings each month as an opportunity for you to be able to learn and share with your journey with bone marrow failure. In order to sign up for a group, all of our groups are listed on our website, which is aamds.org. You can sign up for the group of your choice. Once you register for the group, you will receive a confirmation email. As part of that email, the login information will be available to you to join the group. So now let's go ahead and get started with information about our webinar. Immediately following the presentation, there will be a question and answer session. You can submit your questions at any time during the presentation using the Q&A icon in the engagement panel on your right. Just open up the Q&A window, type in your question, and when you finish typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do two things to help us manage the incoming questions. Submit your entire question all at the same time. And second, please do not share private health information in your question. Our expert today cannot answer any specific questions related to your personal health care. Our expert today is Abhay Singh. Dr. Singh is a hematologist oncologist at the Cleveland Clinic, located in Cleveland, Ohio. He focuses on clinical research and the precursor conditions leading to hematological malignancies with a special focus on myeloid malignancies. His research interests involved studying colonal hematopoiesis of intermittent potential, CHIP, and colonal cytopenias of indeterminate significance, CCUS. We'd like to welcome Dr. Singh, and thank you so much for joining us today.
Thank you so much, Lee, for the very kind introduction. I'll go ahead and share my screen here. Hi, everyone. Today, I will be talking about low-risk MDS, short for myelodysplastic syndrome. Name's Abhay Singh. I'm Assistant Professor of Medicine in the Leukemia and Myelodisorders program at the Cleveland Clinic Taussig Cancer Institute. So our agenda today we'll be talking about what are myelodysplastic syndromes. How do we evaluate a suspected case of myelodysplastic syndrome? How do we risk stratify or determine the prognosis for our patients with myelodysplastic syndromes and the recent changes that has happened in the risk stratification? We'll go over the treatment of low-risk MDS and all the newer therapies that are emerging or are recently approved in the treatment of low-risk MDS. So we'll begin by what are myelodysplastic syndromes? So myelo is another word for marrow. So all the long bones and the flat bones in our body, they have this spongy substance inside of them, which is called bone marrow. The bone marrow is lined by hematopoietic stem cells, or the father or mother cells, if you may, and the activity of these hematopoietic stem cells or the father or mother cells is to produce more and more cells throughout one's lifetime. The very day we are born, the hematopoietic compartment or the bone marrow starts producing these cells that are shown on the screen. And some of these cells go on to become the red blood cells or the erythrocytes. Some of the cells go on to become the white blood cells. More commonly, we refer to them as leukocytes, or the subset that is very important to prevent infection are the neutrophils, as shown on the screen, and the platelets. They all have a different function. So red blood cells, these are cells that carry oxygen throughout our bloodstream and to different organs of our body, and then they provide us the energy to do the daily activities. So when we have less of them, we're told that we have anemia. When the neutrophils are low, the process is called neutropenia, and that makes one prone to infections. And when the platelets are low, we're told that we have thrombocytopenia. The function of platelets is these are the sticky cells that float around in the bloodstreams, and whenever we cut ourselves, these are the first responders that form the initial plug, and they prevent us from bleeding. And the whole of this process is called normal hematopoiesis, or normal blood forming process. Hematopoiesis means blood forming process, and the entire figure shown here is the blood forming process. Now, during one's course of lifetime, so as you can imagine, these cells are working day in, day out. The father mother cells or the stem cells, they're working day in, day out to produce more and more cells. They're rapidly multiplying, dividing, and as with any machinery that works over time, there can certain defects that can happen. In the world of hematopoiesis or blood forming process, those defects are called mutations. Those mutations can happen at several different levels. They can happen at the father or mother's cell level, the stem cell level. They can happen in the levels beneath them, like in the progenitor cells or the daughter cells or several different cells. So these mutations can happen. And once these mutations happen, that process becomes abnormal, and it's referred to as abnormal blood forming process or abnormal hematopoiesis. This can be seen when we do a peripheral blood smear, or we smear a part of the blood taken from the peripheral bloodstream and put it on a glass slide that can be looked under the microscope. And then the pathologist or we look at the white blood cells, the red blood cells, and the platelets. And the thing is, when the abnormal hematopoiesis is happening from some sort of mutation process, these cells start looking abnormal. So the red blood cells, they should look like nice concave discs, but now they're looking very deformed or dysplastic, as we might call them. Neutrophils look different or abnormal, and the platelets look different or abnormal as well. So that's where the dysplastic comes from in the myelodysplastic. So dysplastic refers to abnormal, imperfect formation or growth. So this abnormal, imperfect formation is seen under the slide, but this also renders these cells less functional. They do not function properly, and this manifests as lower blood counts, contributing to anemia, thrombocytopenia or low platelet count, leukopenia or low neutrophil count, or low white cell count. So I think we're coming close to what are myelodysplastic syndromes. But why are they not called myelodysplastic disease, myelodysplastic disorder, and why are they called syndromes? So the syndromes are a group of symptoms which consistently occur together, and that's what we see in MDS or myelodysplastic syndromes. And it's not called syndrome, it's called syndromes because there are several different types of MDS that we see, and we'll discuss over the classification in the next few slides. But myelodysplastic syndromes, they comprise a group of hematological malignancies characterized by, we discussed, abnormal hematopoiesis, low blood counts. This can be anemia, neutropenia, and or thrombocytopenia. It can be isolated or any combination of these three. There is abnormal cellular development, and these abnormal cells can be seen under the microscope. And there are several groups of symptoms that can happen that gives us that entity of syndrome. These can be fatigue, exercise intolerance, easy bruising, recurrent infections, to name a few. Therefore, whenever we get a referral for MDS from our primary care physician colleagues, it is important to conduct a very thorough history and physical examination. Typically, how our primary care physicians send the referral for MDS diagnosis to us is after they review the complete blood count and they see the red blood cells are low, or the platelets are low, or the neutrophils or white count are low. By far, the most common presentation is low red blood cells, that is anemia. This is followed by performing a peripheral blood smear where we can see abnormal looking cells on this glass slide. To confirm the diagnosis of for myelodysplastic syndrome, it is imperative to do a bone marrow examination because that tells us what the blast percentage is. Blast percentage are the number of, or the percentage of bad cells in the marrow, and which have an increased risk of transformation to a more serious malignancy, that is acute myeloid leukemia. We also need to look at the chromosomes because sometimes there may not be a lot of dysplasia, or the cells may not look dysplastic, or the cells may not look abnormal, but there can be certain chromosomal abnormalities that can happen that will give the diagnosis or render the diagnosis of MDS. And more now we are realizing that mutations or the defects that we discussed in the earlier few slides play a crucial role in the diagnosis, prognosis, and treatment of myelodysplastic syndrome. In terms of symptoms, the patients are at risk for symptoms related to anemia, that is from the low red blood cell count, infections, that is from the low white counts, increased risk of bruising, easy bruisability, bleeding from low platelet counts, and there is a risk of transformation to acute myeloid leukemia. That risk is much lower in the case of low-risk MDS. Therefore, when we are thinking of therapies, we're mostly focusing on adequately and optimally controlling the symptoms related to anemia, infections, and bleeding. Moving on to the classification of MDS, this is the most recent updated classification that came out from World Health Organization, the 5th edition. And herein, they defined MDS either with genetic abnormalities, underscoring the fact that it is very important to get a mutation panel for all our patients with MDS. Special notice has been given to mutations in SF3B1 and TP53, and we'll discuss these mutations in the next few slides as well. And then there's also emphasis given on the fact that how the MDS looks under the microscope or morphologically. Are there low blasts or are there increased blasts? Increased blasts can be 5 to 9%, and it's called increased blast 1. Increased blasts can be 10 to 19% in the bone marrow, and it's called increased blast 2. Anytime the blasts are more than 20%, that would render a diagnosis of acute myeloid leukemia. There is also an entity in the classification wherein fibrosis has been now recognized, and it's called MDS with fibrosis. There was another, and then MDS with deletion 5q is a very important entity because there is targeted treatment that we can use in this scenario, which we will discuss. There is another classification, International Consensus Classification, or ICC, that came out at the same time last year, which follows a similar pattern with the WHO classification, recognizing SF3B1, the deletion 5q, and also the excess blasts. But one difference that is important to highlight is that this classification recognizes 10 to 19% of blasts in the bone marrow as AML, which WHO does not. So that is one big difference between the two classifications. There are several other differences between the two classifications, and various groups and expert panels are trying to come together to come to a consensus classification, because this can be sometimes confusing for the treating physicians and also for our patients. I think the next important aspect, once the diagnosis is established and the classification has happened, is to determine the prognosis for our patients with MDS. There has been risk stratification strategies that have been in place for a couple of decades, and more recent reiteration or the revised version came out a decade ago in 2012. It's called the IPSS-R, or International Prognostic Scoring System R, which takes into account blood counts of our patients, the number of blood count abnormalities. Is there only one blood count abnormality like anemia, neutropenia, or thrombocytopenia, and also takes into account the depth or profoundness of those blood count abnormalities. If there's anemia, how profound is the anemia? So this risk stratification takes all those parameters into account. It also takes into account the blast percentage in the bone marrow, which is a very important indicator, as we'll discuss in the next slide. And also how the chromosomes look once the bone marrow examination is done. And we call that cytogenetics as well. So this is the IPSS-R system that is used to determine prognosis or risk of transformation to acute myeloid leukemia. It takes into account, as you can see, the cytogenetics or the chromosomes, the percentage of blasts in the bone marrow, BM is bone marrow, and then anytime the blast percentage is more than 10%, that assigns a score of 3, which if we go to the table beneath, anything more than 3 is intermediate risk, so which is higher than very low and low risk categories. So if we add a cytopenia to this, either low hemoglobin, low platelet count, or low ANC, then we are moving towards the high risk MDS category. So chromosomes play a very important role in assigning prognostic risk to the diagnosis of MDS. Typically, 60% of the patients will have lower risk MDS and 40% of the patients will have higher risk MDS. What we had been struggling for over the last several years was with this intermediate risk category, because it is uncertain whether the disease can be classified, can be treated as a higher risk MDS or a lower risk MDS. And there was this arbitrary cutoff that was put in here at a risk score of 3.5. So this risk score is determined by adding all these variables, which can be done through all the information that we discussed. And if the score was higher than 3.5, although it is intermediate, we considered it at high risk. And if it was less than 3.5, we treated as a low risk MDS. More recently, we have started realizing that the prognostic scoring systems do not take into account the mutations. And there has been a lot of mutation data that has come across in the last decade. So there have been publications or studies that have shown that some mutations can lead to poor outcomes, and some mutations can lead to favorable outcomes. So SF3B1 mutation is one mutation that leads to a favorable outcome. Similarly, there are other mutations that can lead to worse outcomes, but there was no way to incorporate that into the prognostic scoring system. We also realized that the number of mutations matter. Someone with only one mutation has a much better outcome than someone with 2, 3, 4, or several mutations. As you can see here in this curve, the higher the curve, the better the survival. So if you see the black curve here with the 0 number of mutated genes, the outcomes are the best. But if someone has 5, 6, or 7 mutations, the outcomes are the lowest, as seen by the red curve here. Similarly, lower the number of mutations, lower the risk of transformation to acute myeloid leukemia. As you can see on the graph in the right, the yellow patients with the on the yellow curve, they had only one driver mutation, and then they did much better. Higher the curve, the better it is. They did much better than those who had more than 6 mutations, 6 or more mutations. So it was big. We were realizing in the last 10 years or so that mutations needed to be incorporated into the risk stratification system. And that's when the IPSS-R was revised to be IPSS-M, where molecular data or the mutation data was also incorporated. So now, in addition to the blasts and the blood counts and the chromosomes, mutations were also considered in this risk scoring system. And what was developed, which is available as a web calculator, is that in addition to all the parameters that were used for IPSS-R, we are able to put the mutation data for our patients, and then we are able to assign risk categories based on this mutations prognostics system. I want to highlight one important change in addition to the addition of mutations was that now there was no intermediate risk categories. Initially, there were 5 risk categories. These were very low, low, intermediate, high, and very high. Now the IPSS-M has 6 different risk categories, and the intermediate risk category is now broken down to moderate low and moderate high, which helps us think of the disease as a lower risk, anything that is moderate low and below, and high risk as moderate high to very high, and thereby think of treatment assignment based on these risk categories. So this is one big change in addition to addition of mutation data for the risk prognostic system. And as you can see, patients who have in these curves, patients who are very low risk enjoy the survival that lasts for several years, and then for the very high risk, the MDS, the outcomes are lower, and the survival is lower compared to other risk categories. So this risk scoring system differentiates between all risk categories in terms of survival and helps us choose or decide on the most optimal therapy for our patients. I think there is, because the choosing optimal therapy for our patients is so important, and then we need to have full confidence that the diagnosis is clear as well. So I've always been a proponent for second opinion for all our patients, because MDS diagnosis requires a lot of subjectivity. There is a lot of subjectivity in securing the diagnosis, because the pathologist is looking at the bone marrow slides or the peripheral blood slides under a microscope, and they are trying to see how abnormal or how dysplastic the cells are, and there can be variability in someone's interpretation of results from the other. So therefore, in the community, we always wanted that there should be a second opinion, so that there's another set of eyes that's looking through the diagnosis. So this was towards that end, this was a big effort that was just recently reported in 2023. This was initiated in partnership with NIH, the National Heart, Lung, and Blood Institute, and National Cancer Institute, and it included a cohort of patients with suspected MDS or MDS MPN overlap. And this included 918 participants, and there was locally diagnosed data available, and then it was confirmed centrally by expert pathologists. And what was important finding was in this study was that there was major disagreements between local and expert pathologist diagnoses in 20% of the cases. And more important than that was that those misdiagnoses led to patients receiving inappropriate therapy in 7% of the cases. So therefore, the key points from this study were that, yes, second opinions are important. Pathologic diagnosis of MDS can be challenging, and that's because of there's variability in the interpretation of morphology and the quantification of number of abnormal cells, or the quantification of dysplasia that we discussed in the previous slides. And then it's also important that we seek second opinion, because any sort of misdiagnosis inadvertently can lead to suboptimal treatment decisions. So therefore, it becomes important to seek opinions from experts from NCI designated cancer centers, especially in rare hematological malignancies such as MDS. With that, I will move on to the treatment of low-risk MDS. So I think the most important factor here is that we should have a discussion together that what are the goals of the treatment. And typically, because the survival is longer in low-risk MDS, and there is low probability of transformation to acute myeloid leukemia, the goals of the treatment then become controlling symptoms, maintaining or improving quality of life, and reducing or eliminating transfusion needs. There is less focus on cure or reaching complete remission, because there is less risk of transformation to acute myeloid leukemia. So focus becomes that the management should focus on more so symptom relief than on achieving complete remission or aiming for cure, because a cure in MDS comes only with allogeneic hematopoietic stem cell transplant or bone marrow transplant, which can be a toxic process. So there's more harm than benefit in that scenario. So therefore, our goal then becomes to maintain quality of life, to control symptoms, and decrease transfusion dependency. And that's why many of the trials that we'll discuss, or the studies we'll discuss in the next few slides, have transfusion independence as the primary motive or goal of the study there. And this decision has to come together after discussion between the patients and the clinician, because there has to be established goals of care based on current medical fitness and the personal preferences and values. And these goals of care should be visited periodically during different visits and treatments between the patient, caregiver, and physician, and then the entire team. There has to be a lot of communication to provide the best care. So focusing more on symptom relief, and fatigue being by far the most common symptom, I'll go over in some of the slides which will highlight anemia. I also want to emphasize that there can be MDS diagnosis where there is no transfusion needs, there is great quality of life, and in that scenario, there is no point of initiating early treatment, because by early treatment in that scenario, we may be compromising quality of life, and we may be just doing toxicity without any benefit. So it is absolutely okay to observe watchfully and then monitoring blood counts or hematological parameters and then not doing anything. That is not doing anything. That is actually a strategy of watchful observation, wherein we're keeping or maintaining the quality of life. But sometimes the anemia can be so profound or symptomatic, especially when it goes below hemoglobin of less than 10, that we have to consider starting treatment. And in that scenario, we can use erythropoietin stimulating agents, which erythropoietin is a hormone that our body produces to stimulate the marrow to produce more red blood cells. Sometimes in MDS especially, we need more erythropoietin stimulating agent. So that's why we can give it exogenously. And there are agents available called ESA, or erythropoietin stimulating agents, for that purpose. There is another drug approved for the indication of MDS called lenalidomide for the treatment of anemia. We'll discuss that as well. And then some of the newer drugs, luspatercept, which was the first approved in 2020, but there's further approval of its use that I'll discuss as well. So moving on to all the anti-anemia therapies, and then we'll discuss other isolated cytopenias as well, because there can be no transfusion needs. There can be isolated anemia, such as isolated cytopenias or isolated low blood counts, such as low hemoglobin anemia, low platelet count thrombocytopenia, and then there can be multiple cytopenias as well. So we'll go over those scenarios one by one, but we'll start off with anti-anemia therapies, or therapies to counter anemia, which is by far the most common clinical effect of myelodysplastic syndrome. So erythropoietin stimulating agents have been used for a few decades now, and then there have been variable response rates that have been shown in various studies. And this paper looked at almost 1,500 patients who received some sort of growth factor, and the response rate ranged from somewhere from 30% to 50%. I think, considering all the studies that have been done so far, I think the erythropoietin stimulating agents can provide responses in 30 to 50% of the patients. And then these responses can last anywhere from a year to a couple of years as well. Obviously, these are median times. So 50% of the patients will continue responding even after that time. So I do have patients who have been on erythropoietin stimulating agents for more than 2 years and 3 years. So it may vary individually. And there are patients who do not have any response to erythropoietin stimulating agents when have to think of other therapies. And those other therapies, I think one of the new ones that have gained a lot of popularity and attention and is luspatercept. And that's because this medalist trial that was published in New England Journal of Medicine, which is a very prestigious journal in medicine, back in 2020, wherein these patients had received erythropoietin stimulating agents, and they were either refractory or they lost response to erythropoietin stimulating agents, and they were randomized they were given either luspatercept, which is indicated in blue here, or placebo, which is indicated in orange here. And as you can see here, so this is the percentage of patients who had the response. There was increased percentage of response in patients who received luspatercept over 2-month period, over 3-month period, and over 4-month period. And luspatercept did a lot better in getting response rates. And these responses were high in the 30-40% range for patients who had already failed or had lost the response to erythropoietin stimulating agent. And after this study, the FDA approval came for luspatercept for the treatment of anemia in adult patients with very low to intermediate risk MDS. But there had to be some characteristics of the disease that needed to be present to prescribe luspatercept for the patients in need with anemia. And these characteristics were, the biggest one was that there must be presence of ring sideroblasts on the bone marrow examination. So ring sideroblasts was one big consideration. The ASA should have stopped working was another consideration, and then transfusion dependence was another consideration if someone had to be prescribed luspatercept. More recently, this was very recent, a couple of months ago, this was published in another prestigious journal, The Lancet, and it showed, and this was a study which compared luspatercept and erythropoietin stimulating agent called apoetin alpha. And this was in the first-line setting. So patients had not received any other therapy prior to this. And it showed that compared to erythropoietin agents or erythropoietin stimulating agents, luspatercept did much better at 4-month interval and at 6-month interval. And the response rates were higher. And the percentage of patients who responded, who received transfusion independence was much higher in the luspatercept arm compared to the erythropoietin stimulating agent arm. Also, the median duration of response, like the patients enjoyed longer responses on luspatercept, lasting at a median of 126 weeks. That means 50% patients lost response at this time, but there were another 50% that continued to have response beyond 126 weeks. Similarly, for apoetin, it was 77 weeks, which was much lower than the luspatercept arm. With that, there was a recent FDA approval for luspatercept for the treatment of anemia. And now there had to be no prior ESA use. So patients could have, in the first-line setting, luspatercept can be used. And then another important thing is there is no requirement for the ring sideroblasts, which was a big consideration on the previous approval. So now luspatercept is approved as a first-line agent for any diagnosis of low to intermediate risk MDS, where RBC transfusion is required. I think it's a very important study, and it gives us another drug in our armamentarium to prescribe to the patients so that we can treat the anemia, which can be very symptomatic. However, I think I do consider erythropoietin stimulating agents still as first line in some of the patients, especially those with ring sideroblast status that is not positive. So here, as we see in the RS negative group, the responses were quite similar. So 41% and then 46.3%. There are several considerations to that. Maybe we did not have enough patients in the ring sideroblast negative arm to kind of make that connection. But I think there is still role for erythropoietin stimulating agents before luspatercept in some setting, and but we're still learning more. But it's encouraging that we can now use luspatercept in the frontline setting, which is great, so that we can provide symptomatic relief for our patients with anemia. Another medication for the treatment of anemia that can be used in a specific scenario is lenalidomide. So here in this figure, there are normal set of chromosomes, and sometimes there can be deletions that can happen in the chromosomes. So chromosomes carry genetic material of a cell. They're present in the cells, and then sometimes they can get altered, and sometimes they can get deleted. And specifically when there is a deletion that I'm showing here in green chromosome happens in the chromosome number 5, that can lead to a specific kind of MDS called deletion 5q MDS. In this MDS, we typically do not need the dysplasia or the abnormal looking cells, and it can still qualify as MDS. So for the deletion 5q MDS, a drug, lenalidomide, can be used, and it reduces transfusion needs in about 2/3 of the patients. The dose that is typically used is 21 days a month at 10 milligrams daily, and I can go over how this dose was recommended in the next slide. However, we have to practice extreme caution when we're prescribing lenalidomide, because there can be teratogenicity as well, embryo-fetal toxicity, and there can be pretty significant cytopenias, low platelet count, low neutrophil count. So we have to monitor blood counts very closely in the beginning. And then there is also increased risk of arterial and venous thrombosis or blood clots that can happen. However, this is also a drug that is used in another condition called multiple myeloma. And in multiple myeloma, lenalidomide is used with steroids, and it seems like the blood clots were more common because of that combination with steroids in the setting of multiple myeloma. So this is the MDS 002-003 study, in which patients who had deletion 5q, they had response or a red blood cell transfusion independence. So lenalidomide was used for 28 days and for 21 days, and that response was not quite, transfusion independence rates were not quite different between the two groups. That's why, to minimize toxicity, lenalidomide for 21 days has been the preferred regimen. And it showed that 2/3 of the patient no longer needed transfusion by week 24. Lenalidomide also has response in patients without deletion 5q. And this was the study wherein the patients were randomized to either lenalidomide or placebo. So there was transfusion independence in 1/4 of the patients, 27% of the patients, versus placebo, where the response was only 2.5%. So certainly lenalidomide has some role in patients MDS without deletion 5q as well. There are several emerging therapies, and one of the exciting ones that was presented in a major conference earlier this year at American Society of Clinical Oncology ASCO conference was the imetelstat. This is a telomerase inhibitor, and this is the first time a telomerase inhibitor has been used in myelodysplastic syndrome. So the ends of the chromosome. So we looked at the chromosomes here. The ends of the chromosomes, they have telomeres. And as we all age, there's an enzyme called telomerase that starts cleaving or cutting these telomeres short. And these telomere shortening can result in alterations in blood counts and perhaps alteration in hemoglobin count and leading to anemia as well. So this is the inhibitor of those enzymes. So it's a telomerase inhibitor, and it in ideal scenario, prevents shortening of those telomeres. And that's how this study was designed in patients with low-risk MDS, non-deletion 5q. Those were relapsed, that had relapsed to prior erythropoietin-stimulating agents. And encouraging results, I'm only showing you here 24-week results, wherein 28% of the patients had transfusion independence compared to placebo, only 3% of the patients. And this is something where we might see another approval in next several months to a couple of years, but this is still in progress. It has not reached the stage of any FDA approval yet. As you can see, this is the data for mutation-specific responses. So these are all SF3B1, TET2, ASXL1. These are the mutations that can happen very commonly in MDS. And then imetelstat resulted in responses across. Imetelstat is blue here, and it resulted in more percentage of patients responding in any mutation subtype. So very encouraging results, and another thing that might have a role in the treatment of MDS in the near future. There are several other emerging therapies that I've highlighted here. So we discussed the telomerase inhibitor, but there is another phase 3 trial called the Matterhorn trial using this drug called roxadustat, which seems very promising. This study is ongoing. And I also want to highlight another study which combines the two drugs that we've already discussed, luspatercept and lenalidomide. So this is also open for low-risk MDS, and then we eagerly await the results of this study because as individual agents, they induce responses and treat anemia in a very effective way. So we look forward to how the combination might turn out to be. There are several other drugs that are listed here, which are currently in either phase 1 or phase 2 of the clinical trial phases. Next, we'll discuss the treatments for thrombocytopenia. So there can be isolated cytopenia as thrombocytopenia, and there can be easy bruisability, increased risk of bleeding. So in that scenario, if the platelet count goes below 20,000, or if the platelet count is below 50,000 along with bleeding, there is consideration of using thrombopoietin agonists, which is also a growth factor similar to erythropoietin stimulating agents, but it acts on the platelet precursor cells, and it promotes platelet production. The two drugs that have been evaluated in randomized studies are eltrombopag, also known as EPAG, and romiplastim. So there was a clinical trial in 2017 in low intermediate risk MDS that compared eltrombopag versus placebo. And in the eltrombopag arm, 47% of patients had a platelet response and only 3% patients in the placebo group. So that's a viable treatment for thrombocytopenia that is profound or is associated with symptoms of bleeding, etc. Another randomized controlled trial compared romiplastim with placebo in 2014. It was also used for low intermediate risk MDS. And then romiplastim exposed patients required significantly fewer platelet transfusion. However, this clinical trial had to be halted early because there was increased risk of transformation to acute myeloid leukemia in the romiplastim arm. This was further evaluated at 5 years, and it was ascertained that there was no big difference between the two arms in terms of AML transformation, and the results might have been premature at the time when the trial was halted. Next, let's discuss how we tackle multiple cytopenias. So we discussed how we tackle isolated low blood count of anemia or low blood count of platelets, but several times we can see there patients with anemia, neutropenia, and thrombocytopenia. And in that scenario, we can either use immunosuppressive therapy, which is anti-thymocyte globulin, or therapies that are used for high-risk MDS and are approved for high-risk MDS called the hypomethylating agents. So coming to immunosuppressive therapy, it can be effective in producing hematologic responses in a subset of patients with MDS. This subset is defined by patients whose blood cells have this marker called PNH positivity. So that's one marker that I always check for my patients with MDS, because that can help us define or come up with a treatment strategy that can result in hematological responses. This subset of patients that can have response to immunosuppressive therapy have something called hypoplastic MDS. So this means that, so typically the cells in the marrow, the percentage of cells in the marrow should be 100 minus our age. So let's say if someone is 60 years old, the marrow should have 40% cellularity or 40% cells. But in a 60-year-old, if the percentage is 10% cellularity or 20% cellularity, that tells us that the cellularity is less. So it is hypoplastic MDS, and there may be some sort of immune process that is kind of destroying the cells. So in that scenario, immunosuppressive therapy can be useful. We cannot use this therapy for patients who have more than 5% blasts for the risk of hastening transformation to leukemia. And then it seems that this therapy works for patients in age less than 60 years. However, I have successfully used it in our older patients as well, and it can produce hematological response. Based on this study, the hematological response was produced in about 50% of the patients that were given immunosuppressive therapy. There is also a possibility of using hypomethylating agents. They're usually known by the names of azacitidine or Vidasa, decitabine, or Decogen, and these are approved by FDA for the treatment of MDS. They're also being studied for last several years for low-risk MDS, especially MDS that is refractory to first-line therapies. Both agents, azacitidine and decitabine, can help achieve a hematological response in approximately third of the patients. Now, there are several studies, retrospective and prospective, that have studied this, and then responses have been reported in a variable pattern. But I think a good estimate is about third of the patients will have hematological response to these agents. There is also an option for low-risk MDS patients, which is approved for high-risk MDS, is oral preparation of decitabine. And then they're encouraging response rates in that oral pill at decreased dose, and about 50% rates of transfusion independence have been reported. The pharmacological and safety profiles of the oral agent and IV decitabine are similar. However, they can be it can be harsh on the stomach or the intestine, so we have to be cognizant of that and prescribe appropriate medications along with decitabine to counter nausea and GI upset and other things. So often we are faced with the question of whether we should use decitabine or azacitidine. There is not a whole lot of difference in high-risk MDS, but studies have reported that the response rates may be better with the use of decitabine. So decitabine had 70% response rate, overall response rate, and then azacitidine had 49% response rate, and higher rates of transfusion independence, 32% versus 16%. There were some other concerns raised in this study as well, that the dosing probably wasn't equal, because azacitidine in higher risk disease is used for 7 days and decitabine is used for 5 days. So when you do 3 and 3 of both medications, it's probably not equivalent. So that was one thing that that came through this trial. And then I think important thing was this is the same study but reported out last year again with the updated survival analysis. The important thing is that the survival was similar in both the arms. So 5-year overall survival was similar with use of azacitidine and decitabine. But if we need hematological improvement as a more desirable thing for our patient, then I think decitabine may have a better role than azacitidine, although jury's still out, and more data is needed to kind of definitively say that if one is better than the other. Once the disease has progressed after hypomethylating agent, the survival is lower. So the median overall survival based on this study from 2015 was was about a year and a half. So at this point, there does come a role, if the fitness allows and if the age allows, there does become a role of allogeneic hematopoietic stem cell transplant or bone marrow transplant. And I often start thinking of bone marrow transplant in my patients once they reach the stage of requiring hypomethylating agents in low risk MDS. I think it is also very important to get next generation sequencing or mutation to look for any targeted agents that can be used. That's why when we started off with the mutation slides, it is very important because it's the mutation that's kind of initiating the MDS process. So in all these flowcharts and in many presentations and slides, you will see that NGS for targeted therapy is something that's needed. So at any point of time, a patient undergoes a bone marrow examination for either lack of response, for either for the fear of progression to leukemia, NGS should be done because it provides us an opportunity to use certain drugs. IDH inhibitors IDH is a mutation that is commonly seen in MDS, and there are oral pills that can be used against those mutations. And then these mutations, we knew that these were effective in treatment of myelodysplastic syndromes, more so in higher risk. But I think now there is approval to use ivosidenib or IDH1 inhibitor medication for relapsed refractory MDS as well. So on October 24, which was like 6 weeks ago, or 2 months ago, the FDA approved ivosidenib, IDH1 inhibitor for adult patients with relapsed refractory MDS. So after azacitidine or decitabine flavor is the exposure, we can use these IDH1 mutation specific drugs for our MDS patients. And then while we're looking for bone marrow transplant, if patients are eligible. I think encouraging response rates have been shown. We discussed IDH1, but in IDH2 mutated MDS as well. And although this study primarily included patients with high risk MDS, we want to bring your attention to the low risk MDS cohort as well, who had failed prior erythropoietin stimulating agent, and there were encouraging response rates in the low risk MDS. So enasidenib may also have a place. So again, underscores the importance of getting mutation testing or next generation sequencing testing to know if there's any targetable mutations. Always encourage my patients, and we should always be thinking about clinical trials because we're still there's lack of number of approved treatments for MDS. We're still learning the mechanisms of disease onset, disease progression, and then if we can use targeted therapies in a clinical trial setting to bring drugs for our MDS patients, I think that's always the strategy to go. So we should always consider enrollment into a good clinical trial for which we might be eligible for. I think I cannot emphasize enough how important collaborative care is. Collaboration between treating, it might be local oncologist, collaboration between primary care physician, collaboration between someone at a NCI designated cancer center, collaboration or like communication, close communication between the patient, caregivers. We discussed the support groups at the beginning of the session. There are Facebook groups, and I think it's very important to stay active to learn about the latest and greatest advancements in the treatment of MDS. Having a close communication loop with our nurses, our nurse practitioners. I think it is all very important to have a good communication loop while we're doing treatments for MDS. And it's very important to communicate how you're feeling, how the disease is affecting, because there might be something that as a team we will be able to achieve that aligns the best with patients' preferences and values. I think so. Cannot emphasize the importance of enough to having a very close communication loop with your care team among fellow patients and caregivers. With that, I thank you all for your time and attention, for taking the time to listening to me. I'd be happy to take any questions now.
Thank you so much, Dr. Singh, for the wonderful presentation. And we do have a few questions. Our first question, it's actually a two-part question. They'd like to know, Do you have many patients that have not needed transfusions at all for a year or more who have been taking luspatercept? And the second part to the question is, have there been patients who have had a great response at first to luspatercept and then it stopped working for them?
Yes. So I think both are wonderful questions, very practical questions. And I think it's usually we've seen that not requiring transfusion while on luspatercept for closer to 6 months, even more. But I think a year or more is less frequent. It can happen, but it is very less frequent. And coming to the second question, yes, I have seen patients, and several of my colleagues have had situations where we see a very encouraging initial response to luspatercept, and then which is followed by loss of response. That does happen. But I think one important thing is that luspatercept actually comes in 3 different dose levels. So often when we lose the response at the initial dose, which is 1 milligrams per kilogram, there is opportunity to go a dose level higher, which is 1.33 milligrams per kilogram, followed by 1.75. So I think one of my dear colleagues, Dr. Shudipto Mukherjee, did this wonderful analysis where he found that luspatercept was being discontinued at first initial dose for the thought of lack of response. But I think at that point, we should go to the higher dose to kind of get that response back. So there's opportunity to go to 2 higher dose levels.
Thank you very much for that answer. Our next question is, are there ever circumstances when low risk MDS when a low risk MDS patient should consider a transplant?
Yes, I think again a very good question, a very practical one. I think when we are considering erythropoietin stimulating agents or luspatercept or lenalidomide as initial therapies, there is less role of transplant in those scenarios. However, once we see that the drug has failed in the initial stage, or we are going to a therapy such as hypomethylating agent, that is when I start discussing with my bone marrow transplant colleagues and also start having discussions with my patients that if the hypomethylating agents are not able to provide the response, that may be the strategy, because after that, you're looking at clinical trial options, which can be promising, but sometimes the clinical trial options are not available. And at that time, I start considering bone marrow transplant for my patients once they've lost that initial response to initial therapies.
Thank you, Dr. Singh. Our next question we have is, for low risk MDS, I started out as watch and wait. Why would we not just go to treatment? I'm still watch and wait, but I'm not sure what I'm waiting for.
Yes, I think yeah. So I think sometimes we think that something needs to be done, understandably so, but there's lack of data or lack of evidence that suggests that treating early prevents any sort of progression. And in fact, we might do more harm than benefit by exposing to treatment-related toxicity. So watchful observation, I think the only time when we should consider treatment is if there are symptoms from the disease, if there was profound fatigue, shortness of breath, interfering with activities of daily living, interfering with quality of life. Yes, absolutely. Starting treatment makes a lot of sense at that point. But if there's no symptoms and blood counts are in a very adequate range, then starting treatment just increases treatment-related toxicity without providing any additional benefit. So I think I've had a patient, I have patients in similar scenarios where we're doing watchful observation. And then the part of watchful observation is that someone's keeping an eye on your blood count, that if there's any change that requires treatment, that can be discussed, and also meeting at a regular basis to assess symptom burden and see how the symptoms are evolving to consider treatment at this stage. So watchful observation is different than not doing anything, because in watchful observation, someone's watching your symptoms and blood counts closely, and then at the first sign or any concern, treatment initiation will be discussed with you at that time.
Thank you. And this question comes from a patient who has low risk MDS, and they've been on watch and wait for 9 years. They had a procedure, which then they coded, and then they were in a coma for approximately a month in ICU. Prior to this, they were not transfusion dependent. They'd like to know, could have being in a coma, now they are having to use transfusion. Could that trauma have now made them blood transfusion dependent?
Yes. So just being in the ICU, and especially going through that process, going through the trauma of chest compression, other things, can be very stressful for the entire body, as we understand, but it can be especially stressful for our bone marrow as well. So it can suppress our hematopoiesis, or the process of blood forming, and sometimes the recovery can happen in days time, but it can sometimes take a few weeks to months for the normal process or the normal blood forming process to kind of recover from there. So it may be that the process may resume to a normal level, but I think the whole process of being in the ICU and then marrow being suppressed has contributed to the lower blood counts and increased need for blood transfusion.
Thank you, Dr. Singh. Our last question is, for low risk MDS, is it ever recommended for combination therapies, or is that just for high risk MDS?
Yeah, so great question. So a lot of combination therapies are being tried in the setting of high risk MDS, in a clinical trial setting. In the low risk MDS setting, there is a study that I discussed in one of my slides that combines two of the approved agents, that is luspatercept and lenalidomide, as a combination. So that study is ongoing in low risk MDS. And then I think there are, in specific scenarios, there are combination studies going on in TP53 mutated disease, and then another combination that I didn't highlight a whole lot, but in some scenarios there can be success in using erythropoietin stimulating agent plus granulocyte colony stimulating factor, colloquially known as growth factor. So combining erythropoietin stimulating agent and growth factor can help in achieving hematological responses as well. But yeah, so in high risk MDS, in clinical trial setting, more combination drugs, less so in low risk MDS, but there are some clinical trials happening with combination in low risk MDS as well.
Thank you so much, Dr. Singh, for sharing your time and your expertise with all of us today. This webinar was recorded, and it will be available on the webinar platform within the next hour, and it'll also be placed on our website within just a few business days. We'd like to thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 40 years. This concludes our webinar. Thank you, everyone, and have a wonderful holiday.
Thank you. Thank you so
Bye,
much.
Dr. Singh. Thank you.
Bye. Thank you.
Bye-bye.